Hello and welcome everyone. Today we'll be discussing an important topic, that is how to give chemotherapy to hematological malignancy patients in ICUs and the various complications that are associated with it. Some hematological malignancy have short tumor doubling time and associated complications which require immediate chemotherapy. So giving chemotherapy in the ICU is associated with a mortality of around 25 to 30%, while those who do receive have good remission and survival, that is up to 70% at 12 months. But there are certain risks which are associated because of the chemo that is given, which can worsen the tumor complications leading to life-threatening conditions. So an intensivist must be aware of all this before, so that they can be able to manage these patients and ensure that they survive their ICU stay. So the common scenarios which require such urgent chemotherapy are acute leukemia, hyperleukocytosis leukostasis, tumor lysis syndrome, DIC. There are some secondary conditions like HLH and less frequent ones like tumor induced microangiopathy and plasma hyperviscosity. So going one by one, the first and the most common one is hyperleukocytosis and leukostasis in acute leukemia. The definition is that if the WBC count is more than 100 into 10 to the power 9 per liter, though complications can start as low as 50. It present in up to 20% of the AMLs, 30% of the ALLs at diagnosis. The symptoms of this condition are non-specific like fever, dyspnea, mucocutaneous bleeding, and pulmonary involvement is a very common finding, like this cough, dyspnea, hypoxemia, lung infiltrates on chest x-ray. Brain involvement with delirium, focal neurological deficit, seizures, ischemia, and hemorrhagic lesions are very common. Pathophysiology is that the hyperviscosity syndrome due to the cellular components is a major factor over here. The endothelial dysfunction from blast cells adhering to and migrating across the endothelium leads to hemorrhagic phenomena. Exaggerated expression of integrins and selectins by leukemia cells cause vascular barrier rupture and perivascular tissue infiltration. Management and treatment of this condition: ICU admission for close monitoring, because a high mortality is seen in the early initial days. Address the organ failure, the hydration, and the need for cytoreduction. The use of hydroxyurea to gradually reduce all cell counts and decrease the hospital mortality. Leukapheresis is a rapid removal of circulating blasts, though it doesn't affect the formed cellular plugs and bone marrow proliferation. Dexamethasone during induction chemotherapy can reduce the short-term mortality by dyno-regulating adhesion molecules expression leading to leukocyte adhesion. Hydroxyurea reduces the WBC count. Clinical manifestations of leukocytosis known to lower hospital mortality in hyperleukocytemic AML. It is recommended to reduce the WBC count below 25, and leukapheresis is done as a frontline treatment in stasis, rapidly removes the circulating blasts, and there is no significant impact on the overall survival in a large study, however. Dexamethasone, as we have discussed, reduces the short-term mortality during induction, potentially reduces the leukostasis. Again, a lack of prospective data supports is widespread usage. The next thing is the tumor lysis syndrome. In this, the definition is it's a life-threatening condition which is caused by rapid release of tumor cell contents into the bloodstream, including the DNA, potassium, phosphate, LDH, and cytokine. So these are the components which are going to produce their side effects when they are released into the blood. The degradation of the DNA causes an increase in the uric acid and the formation of uric acid crystals. The released phosphate precipitates with the calcium, causing hypocalcemia and calcium phosphate crystal formations. The lab abnormalities are hyperuricemia, hyperphosphatemia, hypocalcemia, and hyperkalemia. These are very diagnostic of TLS. A clinical TLS is characterized by the combination of these abnormality with the AKI, seizure, ventricular arrhythmia, and sudden cardiac death. The risk factors are, there are some high risk patients, that is common in patients with chemosensitive malignancy and high tumor burden, such as hyperleukocytic leukemia and high grade non-Hodgkin's lymphoma, that is like a Burkitt's lymphoma. The spontaneous TLS can occur in up to 40% of the high-risk patients. The impact of AKI is very severe. It worsens the prognosis with 66% mortality at 6 months compared to 21% without the renal failure. The management is hydration and electrolyte balance. Hyperhydration, that is 3 liters per body surface area, is crucial to prevent the AKI. Alkalinizing is not recommended due to the risk of calcium phosphate precipitating. Correct the hyperkalemia with the polystyryl sulfonates without ECG changes, and if you do find ECG changes, you can give an insulin glucose infusion. Avoid the calcium supplementation except in case of seizures or ventricular arrhythmia due to the hyperkalemia. Hypouricemic therapy favors rasburicase over allopurinol in the biological TLS stage. Ensure that the G6PD deficiency is ruled out before you administer the rasburicase to prevent methemoglobinemia. Renal replacement therapy can be considered early for persisting hyperphosphatemia to prevent and mitigate the AKI. Monitoring is important, and in ICU, the monitoring is the continuous clinical ECG and biological parameters during the acute phase. You check for the potassium, phosphate, calcium, urea, uric acid, creatinine, LDH every 6 to 4 hourly. And the additional consideration is like spontaneous TLS is a high risk patient, indicates the need for urgent chemotherapy and close monitoring. Electrolyte disbalance, you need to focus on your potassium and phosphate promptly. Use phosphate binders cautiously as their efficacy is disputed over here. The next condition that we are dealing with is DIC. DIC is defined because of the clinical forms, that is hyperfibrinogenic DIC. In this, you find hemorrhagic presentation commonly in hematological malignancy like an AML. The antifibrinolytic DIC, that is thrombotic manifestations, often associated with myeloproliferative disorders and asparaginase treated ALL. So the incidence and pathophysiology, the incidence is around 25% in acute leukemia, higher incidence of hyperleukostasis and leukocytosis, particularly in AML with normal karyotype and FLT3 ITD mutations. Now, the pathophysiology is that the leukemic cells produce tissue factors which trigger the coagulation cascade via the extrinsic pathway. The endothelial activation and the dysfunction lead to multifactorial processes. In APL, leukemic cells express tissue plasminogen activator, increasing fibrinolysis. The diagnostic criteria: the International Society of Thrombosis and Hemostasis, the ISTH, has developed some criteria for DIC, that is thrombocytopenia, PT, fibrinogen, and the increased FDP or D dimers. The Japanese also have a score which has platelet-free diagnostic score for DIC in hematological malignancy. The clinical manifestations and the presentation is that in severe presentation you can have cerebral hemorrhage and intraalveolar hemorrhage. I'm not going into the details of the DIC, they are found everywhere nowadays. The management of active bleeding: the platelet transfusion to maintain a threshold of 50 is important, and fibrinogen replacement therapy to achieve a level of more than 1.5 grams per liter. AML associated DIC, the emergency cytosol reduction and chemotherapy is important. ATRA for APL induced DIC administered immediately on diagnosis. This has a very high outcome impact on the outcome and has a very good outcome over here. So giving ATRA is important. Management for ATRA induced differentiation syndrome with DEXA and hydroxyurea needs to be done. Non-APL AML with targeted therapies like increased reports of differentiation syndrome with IDH1 or 2 and FTL3 inhibitors. So thrombotic manifestations in ALL patients secondary to the L-asparagine is thrombotic effects, reduces the asparagine levels, lower hepatic synthesis of antithrombin and fibrinogen, causing a prothrombotic state. So ISTH recommends antithrombin concentrates to achieve levels of 80% to 120%. Low molecular heparin thromboprophylaxis with platelet count more than 30 without bleeding. Fibrinogen substitutes to maintain a level of 0.5 gram per liter. Use unfractionated heparin or low molecular weight heparin over oral anticoagulants for treating thromboembolic events. The next is tumor-induced MAHA, that is microangiopathic hemolytic anemia. Definition here is that MAHA is considered a differential diagnosis of paraneoplastic DIC where the peripheral thrombocytopenia is present. Now, approximately 10 to 15% of the case show coexisting MAHA and DIC, reflecting the tumor-induced endothelial activation as well as dysfunction. The pathophysiology is the MAHA primarily involves excessive platelet adhesion and activation linked with the increased von Willebrand factor activity from the endothelial origin. Decreased Adams 13 protease activity due to microthrombi formation causing thrombocytopenia and intravascular hemolysis with cystocytes. Erythrocyte fragmentation can also be due to DIC or the microvascular metastasis or bone marrow involvement. The diagnostic criteria is the triad of diagnosis, that is thrombocytopenia, elevated LDH, and presence of cystocyte with a negative direct antiglobin alloglobin test. The search for cystocyte is essential diagnostic element and should be repeated if initially negative. The incidence and characteristics are: the incidence is of the paraneoplastic MAHA is more common in patients with solid tumors, followed by non-Hodgkin's lymphoma. The characteristic is that it is often presents in unclassified forms not fitting the hemolytic uremic syndrome or the TTP parameters. The decreased ADAM13 activity is common but does not reach the diagnostic threshold for TTP. Now, the management and the treatment over here is it's a diagnostic challenge in suspected TTP without a determined etiology. Failure of plasmapheresis suggests that probably it could be paraneoplastic MAHA, warranting a bone marrow biopsy. The treatment strategies are steroids, rituximab, and caplacizumab, which are not universally recommended and should be evaluated on a case-to-case basis. Emergency chemotherapy is not only treatment shown to be associated with survival. The exclusion of other etiology needs to be done. Rule out infections, treatment-related etiology like impact of other chemotherapeutic drugs. Immunomodulatory drugs may trigger immune-mediated TTP, although ADAMS13 autoimmune expression through autoimmune expression of for ADAMS13. Now, coming to the transplant-induced MAHA, in those cases, recognizing complication of hematopoietic stem cell transplant. Finally, we come to the secondary HLH. The definition here is it is a hyperinflammatory state occurs in cancer patient due to excessive macrophage stimulation from inappropriate cytokine production. So the key cytokines involved are the interferon gamma from CD8 plus T cells and interleukin 6 and tumor necrotic factors. The loss of regulation by the natural killer cells and cytokine production by activated macrophage further amplify the inflammation. The clinical and biological signs, they are non-specific symptoms like high-grade fever, lymphoadenopathy, and hepatosplenomegaly. Biological signs like cytopenias, hepatic cytolysis, hyperfibrinemia, hypertriglyceridemia, coagulation disorders. Hypophagocytemia is particularly associated with increased mortality. Hemophagocytosis is often seen in the bone marrow aspiration, but it is actually not a diagnostic criteria. The diagnostic criteria is the HLS 2004 diagnostic criteria is used. You need to have any 5 of the 8 factors. You can see the table. The H score, that is the HLH probability score, is an alternative diagnostic tool. The incidence is that oncohematological diseases and which account for 97% of the malignancy induced HLH cases. Non-Hodgkin's lymphoma is the most common cause, approximately 74% of the cases, followed by leukemia. Regarding the treatment and management, urgent treatment needs to be given with high-dose dexamethasone and emergency etoposide-based chemotherapy. Completion of the first-line chemotherapy appropriate for the lymphoma subtype improves the prognosis. In special cases, you can do the Epstein-Barr virus-induced HLH requires the rapid administration of rituximab to deplete the infected cells. New treatment options are the JAK inhibitors, the use of monoclonal antibody targeting the interferon gamma, and consideration should be done for the etiology that actually is causing that HLH, which should be the primary line of treatment. New protocols to reduce the etoposide toxicity should be used. Coming to plasma hyperviscosity, the definition is that it is caused by an abnormal increase in the plasma protein, that is immunoglobulins. IgM, due to their pentametric structure and high molecular weight, are particularly implicated in the Waterston microglobulinemia is a common etiology. So the presence of cryoglobulin can exacerbate the hyperviscosity through cold-induced polymerization of the immunoglobulins. So the incidence is the prevalence of the disorder is 40% in Waldstrom cases and 3.4% for multiple myeloma. And if you look at the clinical signs here, you need to have a triad, that is headache, delirium, tinnitus, ataxia, that is a neurological. In visual, you need to have blurring and myodesopia, and in mucosal places you can need to have bleeding, that is epistaxis or gum bleed. So for diagnosis you need ophthalmological examination which confirms the diagnosis with retinal hemorrhages. Serum protein electrophoresis shows monoclonal hypergammaglobulinemia with elevated levels of IgM, IgG and IgA. Screening for cryoglobulinemia is recommended, especially with IgM involvement. Complications and emergency management. The main complication is thrombosis, digestive and cerebral bleedings, and the management over here is ICU admission, hyperhydration, elimination of factors increasing the hyperviscosity. Plasmapheresis is important and essential. You may need 1 to 3 sessions to resolve the symptoms. For asymptomatic patients, retinal changes often respond to single therapeutic plasma exchange. So coming to the etiological management, follow-up after the plasma therapy needs to be done. Initiate the etiological treatment and do a baseline after 4 weeks. Treat the Waldenstrom. Bulky disease, you need to give the chemotherapy and the rituximab combination. Low disease burden, then you can give a dexamethasone, rituximab, cyclophosphamide. For noble agents like proteasome inhibitors and BTK inhibitors can also be used. So finally, we have the myeloma associated complications. These are life-threatening complications like hypercalcemia and AKI, common in newly diagnosed and refractory multiple myeloma, often necessitate ICU admission. Light chain cast nephropathy is seen. Primary cause of reversible AKI in multiple myeloma is characterized by lower urinary albumin excretion and high free light chains, level more than 500. Early reduction of serum FLC is crucial for renal recovery and survival, especially in patients requiring renal replacement therapies. The management of the MM-associated AKI is symptomatic measures. High-dose steroids are critical. Hyperhydration with saline. Urine alkalinity is controversial and should be avoided. Hypercalcemia treatment. Rehydration and intravenous bisphosphonates adapted to estimate GFR. Palindronate is preferred over zoledronic acid due to lower renal toxicity. Calcitonin is used concurrently for immediate effects. Nephrotoxicity is seen. So in this next drug that's to be used is the steroids. High-dose steroid 40 milligrams per kg, improve renal recovery, should be administered immediately. Prudent hydration needs to be done to reduce the dexamethasone related side effects. Anti-plasma cell chemotherapy needs to be done, which reduce the burden of the disease. And the standard of care is again high-dose steroids with proteasome inhibitors. Bortezomib is effective and well tolerated. The other new drugs can be used but with limited toxicity and renal metabolism. In the future, the treatment is like combination of bortezomib with monoclonal anti-CD38 antibody, expected to improve the outcomes. In extracorporeal removal of the free light chains, plasmapheresis can be done, and use of new generation high cutoff protein leaking dialyzers can be used. Thank you for your patience.